Hello, and welcome again to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier consisting of review articles centered on a major topic important to surgical oncologists. I'm John Vasallo, managing editor of the series, and for our fourth podcast, we will be discussing the January 2022 issue devoted to disparities and determinants of health and surgical oncology. Here to discuss topics such as disparities in care, creating a diverse workforce, genetic testing, and why we must prioritize inclusion and equity for our patients will be our consulting editor, Dr. Tim Pollack, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editor of the Disparities and Determinants issue, Dr. Lola Fyanju, the Helen O. Dickens Presidential Associate Professor and Chief of Breast Surgery of the Abramson Cancer Center at the University of Pennsylvania in Philadelphia. Welcome to both of you, and over to you, Dr. Pollack.
Thank you, John. I'm really happy to join Dr. Fyanju tonight as a consultant editor on this very important issue of surgical oncology clinics. Traditionally, surgical oncology clinics is focused on disease or organ-specific cancer topics, but identifying topics for this year's issues, I believe that it was critically important to address disparities and determinants of health within the larger field of surgical oncology itself. So we are extremely lucky that we have Dr. Fyanju, who served as our guest editor of this important issue. As you heard John mention, Dr. Fyanju is the Helen O. Dickens Presidential Associate Professor and Chief of Breast Surgery at Penn Medicine at the University of Pennsylvania Health System. Dr. Fyanju is an academic breast surgeon who conducts health services research that has a specific focus on disparities in breast cancer outcome and treatment, as well as improving the quality and efficacy of breast cancer delivery using the principles of value-based health care. She is well known for her work with healthcare disparities, and as such is eminently qualified to be our guest editor. In that role, she assembled a wonderful group of authors for this volume, and it has been a real joy to read this volume and to have the opportunity to talk to Dr. Fyanju tonight. So Lola, we'd like to welcome you to the webinar tonight, the podcast, Surgical Oncology Clinics.
Thank you so much. Really glad to be here.
Fantastic. So there was such a great wealth of different articles we could have discussed tonight, but I've identified a few that in particular that I'd like to pick your brain about, if you will. And maybe we'd start off with the first article by Dr. Dillon and colleagues on disparities in genetic testing for heritable solid tumor malignancies. Genetic testing offers potentially life-saving tools to identify and intervene for high-risk individuals. And it's critically important that patients have access to genetic testing to inform not only their treatment, but help with discussions around prognosis and also therapeutic planning. So disparities in access to genetic testing can have serious implications for different patient populations. And in reading this very interesting article by Dr. Dillon and colleagues, I was particularly struck by their mentioning of the ways that genetic testing and disparities in access to genetic testing can impact different patient populations. And I was wondering if you might share with us some of your perception, especially as a preeminent breast cancer surgeon, about the role of genetic testing, perhaps in particular how it may impact women who have breast cancer relative to their care.
So genetic testing is obviously an incredibly important tool that allows us to personalize the delivery of care for patients with cancer of all kinds, but particularly breast. And one of the issues with breast cancer is that some groups are known to have high levels of certain types of genes that predispose individuals to breast cancer. One group that's known are Ashkenazi Jews, are known for having higher rates of BRCA1 and BRCA2 mutations. But a little known fact is that African Americans also have higher than average rates of those mutations, and yet they experience genetic testing at much lower rates. And this has implications for decision-making with regards to surgical care, impacting whether or not women might choose to pursue bilateral mastectomy, that is therapeutic mastectomy, and contralateral risk-reducing mastectomy at time of diagnosis, particularly if they're young at time of diagnosis. But it can also influence receipt of systemic therapy, as we now know that individuals who have a BRCA mutation and have triple negative breast cancer are particularly eligible for and benefit from certain types of systemic therapy, namely platinum-based therapy. So the implications of having that genetic knowledge are huge. And yet we know there are certain groups who would disproportionately benefit from it, but simultaneously are least likely to have that knowledge made available to them. So there's a real opportunity there to close the gap in disparity by improving receipt of genetic testing, improving awareness of women's being potentially at risk for having a genetic mutation. It's all part and parcel of a need for a very holistic approach to care that involves, frankly, risk assessment of a woman's kind of risk for breast cancer by her primary care physician or OB-GYN when she's in her 20s or 30s, maybe earlier, depending on their family history, and then using that to inform whether or not women need to begin early screening and or genetic testing to allow for early intervention and assessment of whether they're at high risk for breast cancer.
Yeah, it's really interesting. In this article, in addition to breast cancer, Dr. Dillon and colleagues also commented on the importance of genetic testing for prostate cancer, gynecologic cancer, and also colorectal cancer. And I was wondering if you kind of think of any themes that run through all these different cancers as to why perhaps Black patients and other kind of traditionally disadvantaged patients may receive genetic testing at lower rates. Is it access to care? Is it implicit bias? Is it that physicians are simply not offering this to certain patient populations? I was curious about maybe some thoughts or insights on that.
There are multiple reasons and multiple levels at which we can see contributors to disparity. So at the patient level, there is a known cultural difference between different groups with regards to the openness and transparency with regards to which you discuss family history. So there are many families of all groups, all backgrounds, where you don't talk about the type of women's cancer you have. And obviously, the category of women's cancer is very broad. It can range from breast cancer to ovarian cancer to uterine cancer to endometrial cancer to cervical cancer, whose causes range from being truly sporadic to being genetic to being viral. And so when you don't have that kind of information, it's very hard to know what your own personal risk might be and how best for you to be guided as to whether you should be considering genetic testing. Another issue is that I would argue that there's a higher activation energy associated with screening and with kind of care engagement for certain other types of cancer. Breast cancer is actually, very prominent in kind of the popular psyche. People are aware of it. You have football players wearing pink in October. The truth of the matter is there's much less attention paid to colorectal cancer. People don't want to talk about ostomies. They don't want to talk about preps. They don't want to talk about a lot of the things that go along with a potential diagnosis with colorectal cancer. So I think we really need to move to destigmatize these other cancers that may deal with parts of the body that people are more sensitive about discussing, and hopefully also make it easier for them to access both education, but also opportunities for screening for those cancers. Again, I think it's harder for people often to get a colonoscopy or even a pap smear as opposed to a mammogram.
A topic that is, somewhat tangential, but somewhat related is just, in this article by Dillon discusses access to genetic testing. I was wondering, though, maybe you could comment about access to clinical trials. That's been an issue that I know Dr. Stewart has looked at relative to colorectal cancer, and even our group has looked at relative to HPV cancers. But could you comment about some of the disparities around access to clinical trials among, Black patients and other, disadvantaged patient populations?
Yeah, so kind of as a tie-in from genetic testing, what I would say is that we know that when there are innovations, there's often an opportunity, unfortunately, for provocation of existing disparities. So that is when genetic testing becomes better and more widely accessible, we know that the gap often widens, with certain people having more access than those who never had access falling further and further behind. We see a similar state with clinical trials, where we know that when we have opportunities for more subtype specific types of trials, that actually those who are already most plugged into healthcare, most aware of their disease, most connected to the healthcare system in general, are also most likely to seek out clinical trials. And the truth of the matter is, even though people would ascribe quote unquote mistrust to certain populations, people of color, for not participating in clinical trials, the truth of the matter is that survey data reveals that the most likely reason people don't participate in trials is they never get asked in the first place. And so, really, we need to empower physicians, clinical research coordinators to adequately screen clinics and provide a truly unbiased approach towards approaching people for clinical trial participation, and then engaging with people in a culturally cognizant way to really speak to their concerns and use language that resonates with them to encourage trial participation. One important thing I've discovered is that people really don't like the word random as part of randomization, even though we know randomization is meant to simply mean that we create similar groups. Therefore, the intervention being tested can be isolated as the main reason for why we might see a difference between those two groups. And that randomization allows for those similar groups to be created. People just hear the word random, and they think you're playing, Russian roulette with their healthcare. And for people who belong to groups, African Americans, Latino Americans, who have historically been exploited by the US healthcare system, you can understand why they are all the more leery of anything that involves potentially not taking their desires and choices into account. So I think the language we use is important. I think the context through which trials are presented is important. And I think equitable approach of people about trial participation is important. All of those things can really improve engagement with clinical trials, as well as ultimately reducing the barriers that may come about with participation once participation is agreed to.
Those are excellent points. And that provides, I think, a perfect segue to the next paper. It's a paper I couldn't resist talking about tonight because it's from my good colleague here at The Ohio State, Dr. Obangassi, one of our superstar breast surgeons here. And she and her colleagues wrote a paper on breast cancer disparities and impact of geography. And we've been talking a little bit about race and ethnicity, but I'd like to introduce this concept of that well, of intersectionality. And how other elements, in addition to race and ethnicity, can impact patients' access to care, and this notion of social determinants of health. And in her paper, she specifically spoke about neighborhood deprivation, this concept of social vulnerability. And I was wondering if you might comment on some of these notions of social determinants of health, intersectionality, residential segregation, and geographic disparities, whether it's relation to breast cancer, which you yourself treat, and or access to cancer care in general.
So rurality is obviously a risk factor for lack of access to care along multiple dimensions. We know that patients who live in rural areas are less likely to be able to access centers that have high volumes of particular surgeries that are more complex and therefore are more likely to have better outcomes for those surgeries. We know that rural patients are less likely to get radiation when required because those often involve daily treatments that they can't simply access. We also know that you can experience healthcare deserts both in urban and in rural areas, such that even if something is a healthcare system is proximate to a neighborhood, if individuals are underinsured for accessing that site, or if there is mistrust of that particular institution, then people might be less likely to seek care there. So with regards to other dimensions along which we see disparity, obviously, in addition to rurality, there is insurance status. There's also just general socioeconomic status, that is, having the disposable income to access care in a system where it is not guaranteed for all. And what we've seen with the COVID-19 pandemic is people are being forced to make very difficult choices, between insulin and food, between diapers and healthcare. And when you find yourself in those situations, people will often choose for the most pressing and obvious need at hand. And therefore, screening goes to the wayside because, after all, screening is for disease you do not feel. It's for asymptomatic disease. It means prevention goes to the wayside. So taking medications that might prevent progression of disease or development of disease will also go to the wayside. We focus again on the most urgent things before us. So intersectionality is an important concept that looks at the idea that if you belong to multiple groups that may experience disparity or may experience prejudice, then your experience engaging with healthcare is, geometrically worsened, so to speak. It's not just simply an additive process. And it also means that if you belong to groups that have historically been privileged, that privilege may also be compounded. But it also means that you may be part of a group that's privileged in some respects and not privileged in others. And what does that put you in the healthcare system? As a result, one of the things I'm really interested in research-wise are modifiable risk factors, because it gets us away from simply focusing on demography. Not that demography isn't incredibly important, because people's lives are very shaped by how the world sees them, what cultural and racial groups they belong to, what neighborhoods they live in, and what type of insurance they have. But we can't fix those things necessarily. We can't change those things, but we can often address some things that are social determinants of health that we could potentially modify or at least intervene upon to help them get the care they need when they need it. So I think that, again, the COVID-19 pandemic has provided an opportunity for better understanding of social determinants of health. That is, the various aspects of a person's life, such as access to transportation, access to childcare, housing security, food security, that may intersect with their own psychosocial state to impact their ability to access care. And so this COVID-19 pandemic has done has unfortunately led us to better appreciate the ways in which social determinants of health transcend all aspects of the health and wellness experience of patients, leading to higher risks of being affected by the COVID-19 pandemic, both medically, but also socioeconomically in terms of disproportionate impact on job loss and loss of childcare, et cetera. So that's all to say is that addressing disparities is a complex issue. It spans multiple demographic factors, as well as factors that we hopefully can intervene upon in order to provide more equitable cancer care in this country.
And, given the importance of social determinants of health, as you've so clearly articulated, can you comment a little bit about, maybe how you screen for social determinants of health in clinic, or how I should be screening? And we ask people, do you get short of breath when you walk a couple stairs? What's your latest, blood sugar? Frequently I can say I'm guilty of not asking people perhaps about how'd you get here today? What's your transportation like? What's your support system like when you get discharged home? And these other important elements that can drive perioperative outcomes. So any advice for our listeners about screening for some of these social determinants of health? And then once you have screened, what's the next step as far as activating people in the system, whether it be our colleagues in social work or case managers, et cetera?
These are great and important questions. The truth of the matter is many of our electronic health records now have the capability to store information about social determinants of health, but the rates of missingness for those fields are incredibly high. So, and when they're completed, often they're completed once and very infrequently, so they become outdated and ultimately inaccurate. So one of the things we need to work on is making collection of this type of data routinized and part of the standard clinical encounter, but also importantly that we make it centralized. That is part of the central part of the EMR that's not encounter specific. One of the things I often notice is that people will pack a lot of important detail, clinical detail, into their note, but they won't necessarily put it into the medical record. And therefore it's not there and available for other clinicians to see and use and have informed their care. I think we need to do a better job of that. It might be that it's not going to be providers who collect that information, but other people involved with that type of screening, whether it's new patient coordinators, whether it's nurse navigators, whether it's social workers. I would say then once we have that data collected, we need to have systems through which there are default referral patterns that allow for that to be acted upon. So at some institutions, the screens do lead to automatic triggers. At my prior institution, Duke University, we use the NCCN distress thermometer, and we've published work on how collection of that data, which transcends several different domains of stressors, including psychological, logistical, spiritual, physical, that assessing those stressors can help us better address patients' needs and proactively connect them with the resources they need. That being said, we know that we don't do as good a job about collecting that data and acting upon that data as we can. So really, we need to work jointly on collecting the data, populating the data in a way that makes it centrally available to all clinicians, and then having routinized mechanisms through which the data can be applied for intervention. And again, we may not know those interventions or not be aware of them. So we also need to work with our health systems to make sure that we have both institution-specific as well as local, state, and national resources available and readily accessible for patients to get the help they need.
So I wanted to pivot a little bit. We've been talking about access to, testing, access to care, changes and differences in outcomes relative to race, ethnicity, and social determinants of health. I wanted to focus a little bit more now around palliative care, maybe end of life. Another article that I singled out tonight to discuss was the article by Dr. Ivy, and then another good friend, Dr. Fabian Johnston, who's at Johns Hopkins and is a real national expert in palliative care, who wrote a great article highlighting how palliative care is so important for our patients to relieve their suffering and optimize their quality of life, and is really should not just be relegated to end of life decisions. However, unfortunately, there is inequity in the access as well as underutilization of palliative care among certain disenfranchised and disadvantaged patient populations. I was wondering if you could comment a little bit about what you perceive are some of the existing barriers to equitable palliative care utilization among patients, especially underrepresented minority and patients who may be in socially vulnerable areas or geographically disadvantaged areas.
So some of the challenges relate to even getting those conversations started. I think it is both cultural, that is American, but also medical cultural in terms of we talk about cancer often in a language of battles and of victories won and lost. And I think that type of language means that we often focus on cancer as something that needs to be vanquished versus something that needs to be lived with. And as a result, it means that the prioritization on living with and making peace with a cancer diagnosis is not placed. It's placed more on overcoming it through curative intent. And so one of the things that the authors of this paper did a nice job of highlighting was just the ways in which it would be very good to have a variety of kinds of doctors engaged in palliative care. For many years, this has been the domain of our oncologist colleagues, our medical oncology colleagues who do a phenomenal job in this work. But there are many times that we've all experienced over the course of our training where you get the call in the middle of the night as the covering surgical resident, and you're meeting someone for the first time with an operable problem, but in an ideally non-operable situation because they have terminal disease. And at that point, no one is engaged with them as to what their goals of care are, what it will mean if they go through surgery. Not only if they survive, but if they're intubated and then on a mechanical ventilation, what is the likelihood of their coming off and what will their life look like if they don't? And so those are the kinds of conversations that need to happen earlier in the process of receiving cancer treatment. It needs to be performed not only by medical oncologists, but also by surgeons. And I thought it was great. They talked not only about the kind of, micro level thinking about how to, for each individual patient, engage in palliative care, but also at a macro level, how to change the palliative care workforce to include surgeons, to include people from, again, a variety of backgrounds, to inform and really think about the care of patients with a disease that ultimately proves to be the cause of their death. One thing we also need to work on, again, is engaging with people as to what palliative care means and distinguishing that from hospice. And I think, and again, beyond that, once we've made that distinction, also helping people realize that hospice is not also giving up. We know that in the United States, hospice is often accessed within only a few days or weeks of a person's death, when technically it's available to anyone who has an estimated lifespan of less than 6 months. And so we know that we're failing our patients collectively in that regard, but our patients who have the least ability to access that for themselves and also the least ability to advocate for themselves the most.
Yeah, those are excellent points. And as you highlighted, these decisions around, treatment, prognosis, palliative care, end of life, it's so critical to have a very clear communication and shared decision making. And I personally think, communication is important. Shared decision making is important. Cultural sensitivity is important. Representation is important. And then that kind of segues into the final article I wanted to touch on tonight with you was the article by Kalicia Clark, another great surgeon from Medical College of Wisconsin. And Dr. Clark kind of tackles the issues of a diverse surgical oncology physician workforce. Because as you've been highlighting tonight, there are so many challenges around disparities, so many challenges around disparate cancer outcomes, and especially as the U.S. population grows and becomes more racially and ethnically diverse, it is important that we have a workforce and a trainee population that reflects the rich diversity in the patient population who we are serving. So I was wondering if you could maybe share with us some of your perspective around this critical shortage of representation amongst trainees and physicians, as well as the pipeline, not only from maybe college to medical school to residency to being faculty, but also leadership positions amongst people who have been traditionally underrepresented. So maybe Lily, give us some thoughts on that.
Yeah, so Dr. Clark is, as you mentioned, a national expert on discussing how to promote diversity in surgical workforce at all levels, because we know that we can't have diverse surgical leaders if we don't have diverse medical students and frankly, pre-medical students, and even high school students who dream to be surgeons one day. In terms of our being a part of that answer or dealing with that problem, I think a lot of universities do engage with their local communities in terms of volunteering with high school students, volunteering with college students. I would argue that beyond just volunteering and giving a lecture, we really need to engage with these students to make them aware of what the process is going to look like and what is involved so they can be prepared early. It's a very different thing applying to medical school if your parent is a doctor versus if you're the first person to go to college in your family. And that disparity is seen across all racial and ethnic groups, but disproportionately amongst people who are Black, who are Latino, who are first generation immigrants. And so paying attention to the disparity that begins when people walk in the door freshman year of college is something that we need to be very attuned to in terms of just equipping people with knowledge of the path. I am struck by how often many people just don't know what goes into becoming a surgeon. And that's something that we can all help with. Why it's important. I don't think the goal is ultimately that every patient has a doctor who looks exactly like him or her. That is not the goal of American medicine. But what we do know is that when we have a diverse medical workforce, all of us become more attuned to the humanity of people who are unlike ourselves and perform better medicine in that way. It means that you're no longer seeing someone as speaking a different language, being from a different racial ethnic group. You're seeing someone who could be the mother of your friend who you were in the trenches with in residency. And I've said this before, but I really do think of surgical training as a form of crucible where you're in the fire with people who become so close to you, spend so much time with them. But even if you start off as very different people, there are inevitably bonds that are forged that change your way of seeing the world and change your way of seeing other people. So that might sound kind of kumbaya, but I do think it's really important in terms of having a diverse surgical workforce. Yes, it also means patients see people who look like them, but it also means that people who belong to majority backgrounds also have ability to practice more culturally informed medicine. I think there are multiple ways we can do that. I think it's about, again, providing opportunities that many people are not even aware of. I think it's about having real reflection in terms of our criteria for both assessing excellence, but also promoting people to the next level. We know that there are higher rates of people leaving residency amongst Black residents in surgery. And we need to think about why that's happening. Is it how they're equipped? Is it how they're counseled? Is it how they're trained? Are they given, frankly, the same critical feedback they're needed to become better? Or are people sometimes being a little bit softer in order to avoid, quote unquote, hurting someone's feelings or being politically correct? That is not helping someone either. So how are we really diving deep into our own biases, who we criticize, how we criticize them, who we promote, and who we hold back? Those are all important things we need to consider as we get people to the next stage and beyond training. After training, we need to really think about our criteria for promotion. The truth of the matter is many people of color in surgery, not that there are a ton of us, but those of us who are here are often asked to engage in DEI work. And that work is variably rewarded by tenure and promotion committees. So if you are spending a lot of time doing work on improving the diversity, let's say, of your surgical residency, and you are providing papers and writing papers on that, but not on things that are leading necessarily to NIH, funded, grants, then you may not be viewed as having spent your time in a way that is similarly successful to others in your department who are performing different kinds of work. So I think part of it is recognizing the value of DEI work as it is disproportionately performed, not only by people of color, but also by women and people from the LGBTQ community. I think it's about having transparent criteria for promotion, which often I'm struck by how infrequently that's the case, that people don't know, oh, I have to have my letters together by year 6 in order to go up for promotion at year 7. And then having mentors who can provide, again, a path. I've said this already a couple of times, but I think you have no idea how obscure the path can look if you've never walked it or you're the first person who's walked it. So having you meet more people who've walked that path, who can guide that path, who can clear some of the branches for you, makes a huge difference and means that we can get people then to the final level, which is actually leading within American surgery. There's a lot of evidence, particularly from the business world, that diversity creates better organizations, that things that contribute to better organizations include turn taking, include having more women actually involved in leadership. All of those things we know lead to better and quicker problem solving that is more diverse in its approach and more nuanced in its solutions. And so it's better for American surgery to have a better, more diverse workforce. And so altogether, it's not just about enforcing and keeping the pipeline full. It's about supporting people all the way across and along that pipeline to the point where they can contribute from a position of leadership. I will also say finally that, people will often say that the best chief diversity officer for any organization is the chief executive officer for any organization. So leadership has to come from the top. If it's something that's part of the executive plan of the leader of an organization, no matter what their racial ethnic background, then that will transmit and that will take effect and actually have an impact. It can't be window service and it can't be ghettoized in positions that are nominally DEI, but have no resources and no power and no authority. So I think that, again, we want to work towards supporting people to keep that pipeline full and then getting to the point where those at the top are not only a diverse set of people in terms of racial, ethnic, gender, sexual identity, religion, backgrounds, but also people who, no matter what their background are committed to that diversity as a measure and a route towards excellence.
Dr. Fayonju, thank you so much. That was incredibly well said. We here at the Surgical Oncology Clinics, share your sentiment that we need to be purposeful in prioritizing such important topics as diversity and inclusion and equity. And therefore, we are so enthused and happy that you were able to put together this wonderful volume for the journal. We agree that there is a true diversity bonus, and one needs to be purposeful in the way that we approach these issues and prioritize these issues. I have learned so much from you tonight, as I have in the past whenever we have interacted. I am extremely grateful to you, Dr. Fayonju, for your work to identify such a wonderful group of oncology leaders to contribute to this volume of surgical oncology clinics. The team of authors that you have assembled really did a skillful and masterful job to highlight the importance of diversity, as well as to incorporate attention to social determinants of health into the care of all cancer patients. I'm convinced that this issue of surgical oncology clinics will serve as well to help identify in which we can continue to try to address disparities in cancer care that will hopefully lead to eliminating persistent inequities that unfortunately still plague our healthcare system. Again, I'm very grateful, Dr. Fayonju, for your time tonight, for the sharing of yourself and your expertise. We wish you well. Thank you very, very much.
Thank you so much for the opportunity to guest edit this issue. And again, thanks to the amazing authors who made it happen.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to the January 2022 issue on Disparities and Determinants of Health in Surgical Oncology, Volume 31, Number 1. The series is available for individual print subscription with online access or individual online-only access. Visit www.surgeonc.theclinics.com to subscribe. This series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter at Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, or Stitcher. Thanks for listening.